Hi, Vanessa.
Hi, Cara.
Do you ever wish we could have a fertility expert on this podcast who could tell us everything we need to know about what impacts fertility rates, what older people who are looking to conceive need to think about and understand and know, and what knowledge can be translated and transferred down to younger age groups? Ever wonder about that?
That feels like a leading question, Cara.
But here we go with an episode covering a set of questions we get all the time.
Mm-hmm.
All the time. And it really, I think I have a really incredible wealth of questions. I get these personally. They come in as DMs, as emails, as texts frankly, from a lot of my old patients or old students or family members who are in that 30 to 40-year-old age range who have lots of fertility questions and transitioning from preventing pregnancy to seeking pregnancy. They have a lot of questions. So it's not an audience we typically address on this podcast. And yet we do in this episode a little bit, talk about sort of questions they may have and issues that they may be tackling. And then lots of incoming about, is this fill in the blank going to impact my kids' fertility in the future?
Yeah, I mean, it was fortuitous that we were introduced to Jaime Knopman by an old friend of mine and her co-author of their forthcoming book, Rebecca Raphael. Title of the book, TBD, which we're very familiar with.
That's not the actual title.
No, but at a certain point, the publisher just says, like, you get what you get and you don't get upset. But Rebecca's introduction to Jaime involved her point that young women and older women all the time say, I wish someone had told me, insert this about my fertility.
And men too.
And then men, it's a whole different conversation because while we're having certain conversations with women, but not all the conversations with women, we're having even fewer conversations with men. Although if you listen far enough into the episode, you will hear the one conversation my mother had with my brothers about their fertility. So stay tuned for that.
Also, shockingly, tidy whities and jacuzzis did not come up in this episode, but everything else did. Everything else did.
Or bike shorts.
Oh, yes, bike shorts did not come
biking.
up.
Yeah, so you'll see we tackle some urban legends, some old wives' tales, although that's quite a gendered term that I don't love, but in this case, you'll see why it's relevant. Her bio is, Cara, it rivals your bio for impressive accolades and credentials.
She has more initials.
She's more initials, and I'm not sure you were both summa cum laude and Phi Beta Kappa. So.
Let's just say one of us was summa cum laude.
But Jaime,
and it wasn't me.
But Jaime, for the purposes of this conversation, Jaime is a board-certified reproductive endocrinologist with years of experience in IVF treatment, IUI treatment, PCOS treatment, gestational surrogacy, and so many other areas. She serves as the Director of Fertility Preservation for CCRM Fertility of New York. And listeners of this podcast will love this tidbit. In order to get her camera higher, when we were recording this, she put her microphone and her tripod on top of Karen Tang's book, It's Not Hysteria. So if that's not just the most beautiful representation,
lifting each other up. I love it.
Women elevating each other in literal and figurative ways. This is a fascinating conversation. Jaime explains really complex, sometimes fraught science and science adjacent topics in really understandable ways. She's non-alarmist. She's really thoughtful. She has kids, our kids' ages, right? She has tweens and teens. So it's just a really, really important conversation.
And it starts from the place, and you'll hear in a second, of an Oprah Daily article that she wrote about why she's an advocate for freezing her daughter's eggs when her daughter reaches the age of 22. So listen and enjoy, and questions, feedback, comments, email, DM them. Let us know what you want to know more about. Hi, Jaime. We're so happy to have you here.
I'm excited to be here. Thank you for having me.
So we have had many, many requests over the years to do an episode like the one we're about to get into. And it straddles kind of two groups of people who are impacted by what you do. One group are women who are of reproductive age and ready to be parents, and they're very eager to be on the fertility journey, or they are eager to be on a new kind of fertility journey. And then there's a whole second layer of people who have reached out who want to be thinking about their kids' future fertility journeys, right? So they're tweens and teens and all of the things that they put into and onto their body and how they use their body and what they're doing with their body, and all of it is going to impact their future fertility. And one of the reasons it feels perfect to have you here is a line that you used in an Oprah Daily piece to describe yourself. And I'm going to read it because it's really what thrills us about having you guest on this episode. You said, I used to be a reproductive endocrinologist specializing in infertility. I primarily helped couples who were struggling to conceive, or treated single women in their late 30s or early 40s who were trying for parenthood with donor sperm. Now, just a short time later, I'm considered a fertility specialist. And in some circles, particularly in New York City, I've become known as the queen of egg freezing. And it's that shift from focusing on infertility to fertility that is so interesting. So can you start by sharing a little bit about your journey and how you got to where you are now?
Sure. It's funny that you said that, because I often think about the dramatic shift that I've seen in the land of fertility medicine over the past 5 to 10 years. When I first started, when I was a young graduate in 2012, I was really only seeing infertility patients. Occasionally, I would see fertility preservation patients, but it wasn't like it is today. Currently, 70% of the patients that I see are egg and embryo freezing patients, right? So it's completely shifted. And I think there's three reasons why. I think number one, obviously we're talking about tweens, so we hate to give social media too much credit, but I think social media really pushed the conversation of egg freezing to its forefront. So people became more aware and more socially acceptable. I also think companies providing coverage, the Googles, the Facebooks, the Apples, so it became that it was more accessible and women could do it where in years past, they may have not had the resources. And I think number three, it was the improvement in the technology, right? So egg freezing was considered experimental until 2012, when the American Society of Reproductive Medicine, which I like to say is like our governing body, removed that experimental label. And so we could offer it to women electively. And because of that, we saw a massive rise. The craziest part was that the pandemic was like pushed it over the edge, right? And the number of women freezing went up dramatically during the pandemic. So that we saw probably the biggest rise we've ever seen. But really, that shift has infiltrated fertility medicine, and we do a lot more now than just taking care of women and men with infertility.
Jaime, can you speak to the role of social media? Because this is very relevant to the conversation. Is it fearful? Like, is the content on social media making people concerned about the environment and, things going on our planet and our culture that would make fertility less, I don't know what the word is, successful, or reduce the longevity of fertility? Like, what is it specifically about social media that's kind of driving this?
I think it became destigmatized. Like for so many years, if you were in our waiting room, people would wear hats and glasses. Like they didn't want anyone to know they were here because I mean, if you think about it, even when we're little kids, right, we all just assume our fertility is going to happen, right? It's something you just assume will be a given. So when you were told you have infertility, I think it was so hard for women and couples to sort of deal with. And there was a lot of like shame and guilt. So people hid that they were here. But egg freezing it was empowering. And women were okay sharing, on social media, like, I just did this. I'm so badass. I'm so proud of myself. And so I really think the conversation shifted because it became more about empowerment than shame.
And do you think that the expectations have shifted? Like, are you starting to hear conversations in younger and younger populations where
Yeah.
they don't assume they're going to be fertile? And what does that sound like?
Yeah. So we're seeing more. And so when I first started doing this, the age of the egg freezing patient was in their 40s, right? I say it was like the OG egg freezers were much older. But now the average age is around 31, 32. And I'm seeing a lot of women in their 20s come in to freeze their eggs because there's more awareness. People are, seeing their friends doing it, seeing on social media, it's being covered. And so they are coming in to have these discussions at younger and younger ages, which I think is amazing, right? Because it means they're more aware of their body. Most of the time, so we used to see couples coming in with infertility sometimes in their 20s. I never see couples trying to have babies anymore in their 20s because most people don't start until their 30s. So by virtue of waiting longer, you're going to see more infertility because the quality and quantity of your eggs will decline. So if you don't freeze eggs, you're almost going to set yourself up to have infertility.
So let's walk through some sort of basic science so that everyone's on the same playing field. And I want to lay out the path of what we're going to cover. Let's cover a little bit of the life cycle of female fertility. What does that look like? What does that language mean? Let's do it also for males, right? And then let's also talk about the pros and cons of a procedure like egg freezing. So let's start at the beginning. Do you want to give us a quick primer on female fertility? Our audience knows a fair amount about the menstrual cycle and they understand hormone cycling. This is an educated crowd, but go for it.
So women are born with all the eggs we're ever going to have. And whenever I'm involved in this high school program, my first question is, when do you have the most eggs you're ever going to have? And inevitably people always get this wrong because it's when you're 16 to 20 weeks old inside the uterus, right? And so you lose a significant amount of eggs from that moment until you're born. So most of us are born with 1 to 2 million eggs. And then we start to lose eggs, that the moment we're born. Most women at the time of puberty have about 350,000 eggs. And then over the course of your reproductive life, you're constantly losing eggs. I like to compare it to skiing, like a ski slope. You may be going along at a green, life's all great. Once you hit 30, that green maybe becomes like double green. Then you're at 35 and you're at a blue. 37, 38, you're at double blue, right? So the rate of loss is going to pick up. It's going to accelerate. And with the increasing rate of loss, you're also going to lose quality, such that the eggs that you have, let's say at 38, have a much lower chance of making a healthy pregnancy. It doesn't mean you can't have a baby. It just means the odds of having a healthy pregnancy per month decline, right? So that's really where female infertility gets hit. It's from egg quality and egg quantity. It's not really that our uterus can't survive, right? It's not that our health isn't good. It's just that we have a shorter duration. Men, on the other hand, are going to produce sperm for almost the entirety of their life, right? We'll see men come in to father babies in their 60s, still producing sperm that can result in a healthy pregnancy. So they have constant production. Now, of course, male fertility also declines as you age, right? 68-year-old sperm is not the same as 28-year-old sperm, but there will still be sperm present. So for years, we've tried to deal with this exhausting supply of eggs and, how best to preserve them. Now, 100% egg freezing is not right or needed by everyone, right? And I'm not here to say, oh, it's for everyone, it's going to be great, et cetera, et cetera. But there are definitely risk factors that women have that make their chance of having even a faster rate of decline increase. Right. And so those are the women that probably should be coming in their early 20s because they need to know what's going to happen.
So can we quickly list maybe 2 or 3 of those diagnoses or those buckets where you think, geez, if you fall into this category, maybe you should be learning a little bit more about this?
The first is, and I have two daughters who are almost 14, almost 11. They hate talking about anything puberty with me, but like, talk to your
Send them
mom.
our way, Jamie.
Oh my God. Sometimes I'm like, my goodness, girls, this is what I do for a
I
living.
was going to say cobbler's children.
Ay, ay, ay. But so what I say is like, you want to talk to your mom about her reproductive journey because we tend to mimic our moms, our sisters, our aunts in terms of, did your mom have an early menopause? And if so, at what age? Was it a spontaneous, meaning did it stop on its own, or did she have surgery? Because if your mom had menopause at 40, there's a really good chance you may have early menopause and an early decline in your egg quality, egg quantity.
Jamie, I hear from a lot of women, though, that their mothers had hysterectomies fairly early because that's what was done in those days. And they actually don't know their mothers went into, menopause because of the surgery, and they don't actually know when their mothers would have gone into menopause naturally. Are there other things that families can know of, talk about, think about that might point to that if they are in the situation where there was an early hysterectomy?
So I'll often say, do you remember your mom having, hot flash, like open the window, close the window, like those hot flashes, right? Because if they took their uterus out, but they kept their ovaries in and they had these symptoms, it's pretty likely that they were also undergoing an early menopause. Or, did your mom suffer from infertility? Because if she did, that may be a sign that she had early egg loss and that you may as well. I always ask about painful menses. Did your mom or your grandmother or your sister, did they also have very painful menses? Because we know that endometriosis tends to be more common in families. So trying to get to the root of that is helpful because you can really guide somebody on, is it really important that you freeze your eggs now? Another big thing is genetics, right? So, I had breast cancer, in my 30s. If I'm a BRCA mutation carrier and my kids have the potential to be a BRCA carrier, they should probably freeze their eggs at a younger age because they're likely going to want to genetically test their embryos, right? And in order to have healthy eggs plus non-BRCA affected eggs, you want to do that at younger ages. So your genetic history is also very important.
Can you pause for a second on that? I was actually and I know many, many people who are affected by the BRCA gene. I did not know that people were testing embryos for the BRCA mutation. Can you speak to that for a second?
We do it all the time. So if you carry or your partner, right, it doesn't just have to be you. If you or your partner carry the BRCA gene, oftentimes your OBGYN or your internist or oncologist may send you here to talk about ways to avoid passing this gene on to your children. And the way that we do that is we do genetic biopsy or genetic testing of the embryo, and we send the embryo cells off to a genetics lab, and they'll tell us if that embryo has the BRCA mutation. And then we can avoid transferring that embryo and sort of remove BRCA from that person's lineage. So we do it pretty frequently here in New York City. We see a lot of patients from Memorial Sloan Kettering, Mount Sinai. So we will frequently work with them to help eliminate this.
It feels important to add, though, on the pediatric side, on the sort of, you're the input, I'm the output, right? For every genetic prediction that we can make, there are so many other issues where the genetic predictability is not there yet. And this adds a lot of, like, a thick layer of complication, because people start to think that an embryo that is genetically tested, if everything comes out looking good, there will be no health issues for that child or as that child gets older. And, I'm sure, Jamie, that you will say, yep, 110%. That is not what this testing means. What it means is these things that we can test for today, we know that those are things that can be decision trees for people, but it's not a perfect map to health, especially when you layer on advancing paternal age. And I think that's just one important little side note is there's a lot of data that looks at paternal age or age of the father when the sperm is donated and when the embryo is created. And one very large series of studies has looked at autism. And there is very clearly an increasing risk of a child being diagnosed on the autistic spectrum as paternal age increases. So that's a good example of something that is not tested for in utero or in the embryo stage, but is a known risk. And then there's so many other unknown risks.
Right. We get asked that all the time. Can you test my embryos for autism? And what I say exactly what you're saying, it's multifactorial, right? So we need a single gene or chromosome number that we can test in the embryo. Otherwise, we can't test for that. And I often say, just because you carry BRCA, you may not get breast or ovarian cancer, right? And who knows where we're going to be in 25 years, right, with screening. So it doesn't mean that you can't have a child who has BRCA. It just means if you have the opportunity to remove that, you may consider doing that. But you're right. Embryo testing does not ensure a perfect child. And obviously, we all know there is no such thing.
Jaime, what about PCOS? Is that something that people who are experiencing that or symptoms of PCOS? I know it can be hard to diagnose PCOS, so there's not a test for it. How does that impact fertility?
So PCOS is a syndrome, right? So you're just exactly what you're saying. There's not one thing that we know that causes it, but we use symptoms to say, do we think this individual may have PCOS? Now, the biggest way that PCOS impacts fertility is ovulation. So I always say you need to ovulate to get pregnant. You need to release an egg. It needs to meet a sperm. But if you don't ovulate or you ovulate at very irregular cadences, it's going to increase the chance that you are going to experience infertility. Now, there's different ways to treat PCOS for those women who desire pregnancy. We can try oral medication, sometimes diet and lifestyle. Sometimes we have to go to IVF, right? It doesn't always work, but it is a very common diagnosis that we see and definitely something that frequently can cause infertility.
You mentioned in the article in Oprah Daily about your own kid having a condition that contributes to an earlier decline in egg quantity. I don't want to get into each and everything, but can you share for our listeners some questions maybe they could be asking, some elements of kids' health that might sort of ring some bells for them that this is a question they should be asking a pediatrician, or if they are at the stage of seeing an OBGYN, that may not come up naturally as part of the conversation about fertility?
Sure. So autoimmune disorders, women who suffer from multiple autoimmune disorders can have an earlier decline in their egg quantity, right? So just like I always use my daughter, she has thyroid disease. She has antibodies in her body that attacked her thyroid. So the thyroid doesn't work the way it should. The same thing can happen with your ovaries. Now, it's hard because we see women in their 30s and 40s. And when do we diagnose thyroid disease? 30s and 40s, right? So we're sort of meshing two things, but I frequently see women who have multiple autoimmune disorders also will suffer from an early decline of egg loss. So I am very sensitive to that. And so when she was diagnosed, I'm like, oh yeah, this is definitely going to be a reason that she should, obviously, like what do they say? The cobbler's quote, whatever it is, but but I'm very aware of it.
In this case, your child is very lucky because you're being a proactive cobbler.
Yeah.
But let's talk about some of the potential negatives of harvesting eggs because, it's not a benign procedure. It's not a nothing burger. It's not free. So can you walk us through a little bit of how you think about we've got a lot of the pros. What are the cons?
So you're right. So number one, you have to take hormonal injections, usually twice a day for about 10 days. So nobody likes giving shots. That's never fun. And it's like a commitment. You can't just come in here, draw blood and leave. You have to commit to us for about 2 weeks. That's number one. Number two, when you take the shots, it's going to cause increases in your hormone levels. So your ovaries are going to grow. You're going to feel bloated. There could be sleep changes, mood changes, et cetera, et cetera. It's a surgical procedure to extract the eggs. You get anesthesia, just like you would for a colonoscopy or an endoscopy, but you do get anesthesia. And then the eggs are extracted vaginally. That procedure, while most of the time benign and less than 1% of the time there's complications, but you can have bleeding, you can get infection. And post the procedure, your ovaries are at risk for what we call ovarian torsion, where an ovary can twist, resulting in another surgery that's an emergent procedure. So 100% it requires commitment, there's risk, and you must be aware of that.
And can you just talk really briefly about ovarian hyperstimulation syndrome?
Yeah. So it's funny. Ovarian hyperstimulation, which we call OHSS, used to be so much more common than it is today.
Yeah,
And the
we used to really freak out about it.
Yeah. We don't see it that much because a very smart fertility doctor came up with a way to trigger egg maturation that did not require HCG. We use a medication called Lupron, and this decreases the risk of OHSS because you get a period 4 days after your eggs come out. So it's like a huge game changer because you're right. When I was a fellow, I used to joke around. We used to run OHSS clinic, right? Because any young person who did IVF would develop OHSS. Now we really don't see it. But in
Will you
select
explain
cases,
what it is?
sure, your ovaries are going to get very, very large, right? And then that HCG, that pregnancy hormone that's in your system to get the eggs to be mature, will cause other hormones, things like VEGF, to be released, and it makes the ovaries large. You have fluid that remains in your pelvis, and you can have really serious electrolyte disturbances, high sodium, low potassium, all these different things, and even really difficult problems breathing, like requiring hospital admission. So it's not a walk in the park.
Yeah, so this is a good example. So many times the parents and trusted adults who are raising kids take the fund of knowledge they have from when they were growing up and they carry it into their parenting, right? They carry it over and that's what informs them. So whether it's talking about IUDs and how dangerous they used to be, another good example in the sort, or looking at, overstimulating the ovaries, the science has changed. The medical approach has changed. A lot of the data has changed. I think it's really important for people to learn what is new so that they can inform themselves. Now, here's something else that has changed. The concentration of THC in weed has changed. And so cannabis use has both been legalized in a lot of places and there's a much higher dose of drug being delivered. So that's another thing. We get that question sometimes about how does that impact fertility or does it impact fertility? I'd be curious to know what you think about that or any other drug use. Opiate use has shifted over time. And so, sort of social shifts and behavioral shifts on account of those social shifts really do have potential to impact fertility too, right?
Yeah. Yeah. And I think in terms of social stuff, like number one, we know, and I tell my kids I will kill them if I ever see them smoking cigarettes. Like it is bad, bad, bad. It's always been bad. It will forever be bad because that is the one, let's call it drug or recreational choice that we know is harmful to your ovaries. It's harmful to your sperm and it makes you go through earlier menopause than somebody your age match cohort. So that's clear.
Is it the nicotine?
Yeah. So it's the nicotine in the cigarette.
So is that true of Zins and vaping and all of that stuff?
The problem with Zins and vaping is that there's not as much data on it yet. But what I say to patients is it's not good for you. Like we know this is not good. Let's just cut this habit as soon as we can. The ones that are more controversial, right? Like alcohol. There is really no clear data that alcohol is bad for your fertility. Obviously, things just shifted, right? We just learned about alcohol and the cancer risk, so who knows? But what I say to patients all the time is a healthy body is like good for a healthy pregnancy. Whether or not that's going to hurt or benefit your eggs or your sperm, we don't really know. But we know you probably shouldn't be having like 2 bottles of wine and eating McDonald's every night, right? Like that's just not good.
What? No one told me.
But on the flip side, I think with fertility, there's so much like blame and guilt and people are like, oh, it's my fault. It's my fault. And so I think we need to remove that. Like eating pasta and having a glass of wine although if you're under age 21, it's not right. But like, that's not causing you
The
infertility.
wine part, not the pasta part.
Right, exactly.
But Jaime, so the weed conversation, right?
Yeah.
Like my mother's conversation with my brothers about weed was that the message she went with was it's going to lower your sperm count. Like that was what she went with. Not like,
and it was pot or hash at the time. Let's be clear.
yeah, I mean,
Yeah.
right. When they were in Spain, it was hash. When they were here, but are you seeing, is that still a concern? Is it just a concern for sperm? Is it also a concern for eggs? Like where does the sort of the world of weed fit in here?
I don't think we really know, to be honest, like the new world of weed, because it's so different.
Yeah.
I do tell patients, obviously, we know you shouldn't be doing it when you're pregnant, so that you have to back off from. And there is more data that it is not good for sperm, right? That men have lower sperm counts. But with that said, do people get pregnant who smoke pot? Yeah, they get pregnant all the time, right? So like, I think it's about making educated choices for your future body and the whole body than just your egg or sperm.
Can we talk about cancer and cancer treatment for a second?
Yeah.
Because there was just a study released about that women are being diagnosed with a variety of cancers at younger and younger ages.
Yep.
What do we know about how people can handle fertility ahead of cancer treatment? What are the steps they can take? What are the questions they should be asking themselves and their healthcare providers? Like, give us some framework. I mean, you are both a physician and a cancer survivor, so I'd love to hear sort of the different sides of that.
I also am the chief medical officer for an organization called Chick Mission, which is devoted to raising funds to provide grants to women to freeze their eggs ahead of cancer treatment. Because we know
That's
that
awesome.
most chemotherapies are going to significantly impact somebody's egg quantity. And it makes sense, right? Because chemo is designed to kill or to stop the growth of rapidly dividing cells. And fertility gametes, sperm, eggs, those are rapidly dividing cells. So it'll knock out frequently your future fertility. And we're so good at treating cancer now that so many young people who are affected with cancer go on to live long, healthy lives, but they may be rendered infertile because of the treatment. So there's a huge push that when somebody is diagnosed with cancer, that they are offered the opportunity to freeze eggs or sperm. Now, sperm is pretty easy, right? In terms of, I mean, just theoretically,
come in a cup.
Right? And then you're like, good, we're good to go. And they could do it the next day. And you're like, great, we have 8 vials. We'll see you later.
Sorry, I couldn't help myself. It's like,
not a doctor.
Not a doctor can say come in a cup. You guys can say whatever
she
you
says
want.
it twice. There we go.
But eggs are harder.
What is the doctor parlance for that? I won't say it a third time.
Ejaculate.
Into
a cup.
A
receptacle. The medical word is cup. Just to be clear.
Sorry, Jaime. I'm the color commentator here. Right.
No,
okay.
I like it.
So there is an awareness. There is what are the things that you've heard people say? I wish they had told me. I wish I had known. Like, are there sort of any of those conversations given all your experience?
Yeah, I mean, I still think that is out there, right? Like, yes, we're making huge advancements in telling women and men what happens to their bodies in terms of their fertility as they get older. But I still sit with a whole bunch of 40-year-old women who say to me, I had no idea this was going to happen. And sometimes I'm like dumbfounded. I'm like, wait, for real? Like, it's so opposite to everything I know, but I realize that it's still we're not always aware that as we get older, we're going to lose out on our ability to have genetic children because of the gametes are going to run out.
Also, just saying, we often shove all sex and reproductive education into the middle school years with maybe one bonus class in high school. And the expectation is that you're going to hold on to this information then for the rest of your life, and you're going to parse it out on a need-to-know basis. Most of the kids who are sitting in those rooms listening to this information are thinking about how to block their fertility, if anything.
Mm-hmm.
They're not thinking, and this has been a through line for decades at this point. I mean, anyone in their 40s, 50s, 60s will laugh at the fact that they spent so much time trying to prevent pregnancy or not get pregnant, only to figure out that later they were really going to struggle being pregnant. So it's like, we know, but we can't rely on this education of 12 and 14-year-olds and then ask them 20 years later, 30 years later to pull out of the recesses of their mind a piece of information that their gym teacher gave them that was supposed to be helpful now, right?
Well, we say like I always say to patients, you go through your 20s being like, dear God, I hope I'm not pregnant. To your 30s, dear God, I hope I am pregnant, right?
That's right.
Because and I remember thinking, I didn't even know how hard it was going to be until I was a fertility fellow, right? Like I was a
That's
resident.
right.
I was like, oh no, I'll wait till I'm 40. And then I did my fellowship and I was like, oh my God, this is actually sort of hard. So I think it's lost because it's just not, we teach people how not to get pregnant. We don't teach them how to get pregnant. But I think that's really where we need to start to fall on our OBGYN colleagues, because we need to introduce this conversation earlier. Like we talk about STDs and pap smears and vaccines. We should also say, hey, by the way, this is what happens to your fertility. You may want to start thinking about it earlier, and not in the way like, oh my goodness, you're 29 and you haven't found somebody, you're a loser. But like, hey, listen, like you have an amazing career, you're doing all this stuff. Just going to put it out there. You may want to consider doing something about it.
Okay, Jaime. So with all of that lead in, is there data that any particular forms of contraception interfere with future fertility? Or how do we even begin to think about that massive question? Because there's so many different strategies in the world of contraception, and some of them, very short acting and others longer term.
So, we hear this all the time, you probably too, that like, oh, the pill made me infertile. The pill does not make you infertile, right? It's, I couldn't say this enough times. It may mask infertility. So if you've been on the pill since you were 17 and you stop the pill at 29 and then your periods are irregular, the pill didn't make it irregular. You just didn't know because you were on the pill for so many years, right? So there's almost no form of contraception that is going to make you infertile. Even back to our conversation about the IUD, like our mom's generations, nobody used the IUD because it ruined your uterus, et cetera, et cetera. Now we put it into young women all the time. We're like, this is a great form of contraception.
My mom was aghast when I got my first IUD. And then she went on to tell me all of the horror stories that she knew about an IUD. I was like, thank you so much. It's already in. So can we have a more constructive conversation about this? But to Kara's point earlier, like science has shifted and changed so much that, we have to be our own best self advocates and also be aware of what's going on, to your point, Jaime, because it's a different world. It's a different landscape than it was.
And multiple terminations are going to increase one's risk for potential infertility down the road, right? Because every time if you got pregnant and you wanted to evacuate the uterus or clean out the uterus, there's risk of uterine damage. So it's so much better to have contraception than to not, and to run the risk of what happens when you don't, right?
Can I ask a very specific question just in that there's contraception, which is prevention of pregnancy.
Yep.
There's once you're pregnant, terminating pregnancy. And then there's this tiny sliver in between, emergency contraception. Can you just speak for 1 second to any data about the impacts of emergency contraception on fertility, specifically because we hear from a lot of later teens and 20-somethings who think of emergency contraception like contraception?
Yeah. See, it does. Emergency contraception doesn't impact your fertility. It will alter your menstrual cycle, right? So that it's sort of like a little wonky for a couple months. What I say to patients who, like my young egg freezers, I'm like, listen, it's, something happened, you needed it, fine. You just don't want to make it a habit. You want to get yourself in a place that you're on, like you have a good plan. It's not that emergency contraception is bad, but like it's meant for emergencies. So let's think about what for your lifestyle is best down the road.
Right. And just to be super clear for those who are like, wait, what? We cover this in our book in great detail, but emergency contraception is a form of contraception that usually, almost always, involves taking hormone and taking it at slightly higher doses than you would in an oral contraceptive pill. And that sort of peak and then trough of hormone, tell me if I'm describing this correctly, Jamie.
You're right. Yeah.
Allows the uterus to quickly shed its lining and just triggers. And the reason it's called emergency contraception is that if you have a fertilized egg that's heading towards the uterus, that egg will never implant in the uterus, so it will not be an established pregnancy. So it's not a termination of a pregnancy. It is a form of contraception. It's just sort of a dramatic one. Is that a fair description?
100%. Yes. You're not having, it's not like having an abortion because there was no implanted embryo.
So,
Right.
Jamie, circling back to your earlier point of contraception masking infertility rather than causing it, what are the things you want people to be thinking about, young women, potentially their parents, if they're involved in the decision making, as they consider contraception in terms of family history and sort of like knowing the larger context of these choices and the potential for, a family history of infertility?
So I think going on the pill, the birth control pill, is totally fine no matter sort of what your family history is. But if your periods were irregular when you went on the pill, you may want to come off of the pill a bit earlier when you're trying to conceive to see if your periods are still irregular, right? And let's say, you put an IUD in and you had prior to that very heavy and painful periods, suggesting that maybe you have endometriosis or adenomyosis and your mom had that. Maybe you take your IUD out earlier so that we can look and see if you too have endo. We call it endo and adeno, like the nicknames, but just to see if that's going
Cute
on for you as
nicknames.
well. Yeah. Everything has like a shortened name so that we can write quicker.
Yes, quicker and illegibly.
Yeah. That's it.
Do you
And
want to
then-
cover STIs and STDs, Vanessa?
Yeah, I do. So another sort of newsworthy conversation is about the HPV vaccine, STIs and STDs, and there's a lot of misinformation out there, Jamie. Could you help us set the record straight in terms of the impact of the vaccine on people's fertility, and also if they are to get STIs or STDs, the impact of on their fertility from those infections and diseases?
I'm a big fan of HPV vaccine. Already have given it to one of my children because we know that it can significantly prevent cervical cancer. So I don't see a negative to giving it.
Can I
The
just give you props to
Yeah.
that? And my children are both male and female and both got HPV vaccine.
Yeah.
Just being really clear.
I think, we have vaccines for a reason, right? We want to prevent a very negative outcome. And there is no data that the HPV vaccine is going to increase infertility, decrease egg quantity, make something wrong with the pregnancy. So I think we have to have faith in the studies and the research and go ahead and use the vaccine. In terms of STDs and STIs, those can damage your fertility potentially down the road because they can cause structural damage within the pelvis. Most classically, they can damage a fallopian tube, right? So when you get, gonorrhea, chlamydia, you can also develop an abnormality in a fallopian tube, which connects the egg and allows the egg and the sperm to meet. And if that tube is damaged down the road, you can develop infertility.
So even though HPV, there's not a vaccine for these other STIs and STDs, but there are treatments. And the sooner a person is treated for them, the less possibility there is for it to impact their fertility. This is a PSA to be in conversation with your kids. You don't need the specifics, but a conversation that might sound something like, hey, you know what? You're home from college. We're going to go to the pediatrician. Or we're going to go to the OBGYN. They can do a full panel on you for STIs and STDs. I'm not asking you any questions. I'm just letting you know. You may not even know you have them. You might not know you've been exposed, but it really affects your health down the road if you have them. They're totally treatable. Here we go.
Well, while we're doing PSAs, one for condoms, please. You want to do one for condoms?
Well, that's a big one because people don't use barrier methods. They're like, I'm on the pill.
That's
Right.
right.
I'm like, it doesn't mean you can't get gonorrhea, right? Because you won't get pregnant. But so I do think, especially in like the 20 somethings now, because of the IUD and the pill, they're like, oh, I'm fine. I'm like, well, not really,
And speaking of the generational thing, so we grew up in the generation that like condoms were, of course you use a condom. We
Yeah.
grew up in the generation that was sex educated around AIDS and HIV. And this generation doesn't have the same fear, and there's declining condom use amongst young people around the world, which means, to Jamie's point, that they can get sexually transmitted infections without being aware, because they're
good
often
news.
asymptomatic.
Right. But here's some good news. So not only are condoms readily available at your corner store and online, but it is also really easy to be screened for an STI.
Right.
So, you don't have to come home and go to your doctor. You can go to a local clinic, to Planned Parenthood clinic, to a school-based clinic, to a college university health system clinic. And these tests are super easy. And often, for chlamydia and gonorrhea, you pee in a cup, like no swab involved. It used to be a serious owie. And like not a small, someone sticking a little very narrow metal Q-tip up a penis is uncomfortable. And it's like, it was a deterrent to going, fine, just pee in a cup. Easy.
Jamie, I don't want to end without a conversation about the impact of eating disorders on fertility.
Yeah.
We know that disordered eating is on the rise. We know it's one of the leading causes of death of young people in this country. But what is often not talked about is the impact on fertility. Can you speak to that for a minute?
Yeah. So, the body's smart. Our bodies are smart. And what happens is when your weight falls below a certain threshold, the body's like, wait a second, we can't maintain a healthy pregnancy here. So you stop ovulating, you stop releasing eggs. But it's not just that you stop releasing eggs, your estrogen levels will start to drop because the brain turns it all off. So it puts you at risk for long-term consequences, not only fertility struggles, but also osteoporosis, right? Bone thinning and bone loss, which can be very serious. What I frequently see is sometimes girls who had disordered eating around the time of their puberty and then go on some form of contraception to help replace the estrogen. When they stop it, the menstrual cycle really never returns in the same way. It was almost like the access wasn't fully mature, then it got shut off, and something just never came back on. So it can really impact your ability to ovulate regularly and can make you need to do IVF.
That's really helpful. Thank you.
And I just would love to do a quick plug for mental health and the mind-body connection with all of this. Can we close on that sort of when this axis that you described, which is the way the hormones communicate in the body, and it's like this cycle, if you will, and there are lots of different cycles going on in different parts of the body at all times. But when the brain gets involved, and we overthink, or we're anxious, or we're stressed, so often that can have a direct impact on the way that these cycles flow. And can you just maybe land on a little bit about self-care and mental health?
Yeah. I'm a huge advocate of support groups, mental health. I'm the daughter of a psychologist. So clearly I'm like, everyone should do it. And I don't shut up at home. So my kids are like, Mom, we've heard a lot more than we need to. But the point is that we get better when we allow ourselves to sort of open up and have people help us work through challenging situations. And listen, I love my daughters, but I may not always be the best person for them to talk to. So it's okay to talk to somebody at school or an outside person or a support group, because that's going to help you get through a very challenging process. And if your mind is in a good place, I think your body oftentimes follows because you're definitely just more comfortable overall.
Jamie, this was so great. We really appreciate you coming on. We will link to all the places people can find you, and we look forward to, what's the title of your book coming out?
It's it's controversial. We have not settled. I liked A Fertile Future, or this was initially why I liked Wear Sunscreen and Freeze Your Eggs. But that has become
that's
right.
fabulous.
That is a Cara. That is
Yeah.
a Cara kind of title. Do they teach you
Yes.
like pithy
No,
puns
Vanessa,
and advice in
it's a
medical
special
school?
quality that only some of us have.
Wait,
Yes.
Cara, I used to write everyone's titles in fellowship for their like research papers. They would come to me and be like, "Knopman, can you come up with a title?" I'm like, "All right, give me a day." So we've taken that and it's a chapter in the book where sunscreen. And
It's
freeze your
very
eyes.
good.
Okay, that's
But it's
awesome.
like, I don't know. You guys probably have talked about this. Our kids, they like want to bake in the sun. I'm like, have we not learned that we need to wear sunscreen? Like, what is going on?
Oh, the
So,
evergreen
yeah.
lessons.
Yes.
Well, here's how I say it. I say to them, you could try this on your kids. What does a 90-year-old woman's butt look like? What does her bare bottom look like? And after the ew factor, it's, well, it's probably saggy. And I say, but is it wrinkly? And they say, no. And I say, why? And they think about it for a while. And then they say, oh, it never saw the sun.
Correct.
That's
Yeah.
all you need.
Not-
Jamie, we're available for title consultation. Ours only took like 3 months along with our
I
care.
love your title.
Thank
When I
you.
saw that book, I was like, that is so true. Because it's so like, your kids are like, oh, it's so cringy. And like, you're so weird. I'm like, that's such a good title for that age group.
Come sit by us.
Yeah.
I hope you'll come back when the book is out, whatever it's called.
Thank you guys. Thank you for having me.
Thank you for the work you do. We will also link to Chick Mission so that folks who are thinking about fertility and cancer treatment have a place to go.
Thank you.
Thanks,
Jamie.
Jamie. Thank you so much for listening. You can email us with questions, feedback, or episode requests at podcast@lessawkward.com.
If you want to learn more about what we do to make this whole stage of life less awkward for everyone involved, our parent membership, our school health ed curriculum, our keynote talks, and more are all at lessawkward.com.
And if you want products that make puberty so much more comfortable, visit myumla.com.